Hi, everybody. This is a presentation for you for Chapter 18 on preoperative care. And I thought I'd do this through a YouTube presentation so you can take your test tonight and have the rest of the night off and study this at your leisure. So this will be material for exam 4, and then it'll also appear for you on the final exam. So what we're going to talk about tonight is preoperative care for surgery. And as you know, surgery is the art and science of treating diseases. And diseases, injuries, and deformities by operations with instrumentation. We perform surgical procedures for diagnostics, for cures, for palliation, for prevention, for cosmetic improvement, and for exploration. We typically have 2 types of surgical settings, and those are elective and emergent. Within the arenas of settings, we have an inpatient setting, and then we have which also can be a same-day setting. The patient can come in the same day of surgery, and then they stay overnight for admission. And then we also have an ambulatory setting, which is generally referred to as an outpatient setting. There are also a variety of clinic settings where the patient will come in as an outpatient center or outpatient, and these are surgery centers. Ambulatory surgery is usually a duration of less than 2 hours, and then a length of stay total less than 24 hours, and typically the patient goes home with a caregiver within hours of surgery. So you as a nurse, it's important to know that when a patient checks in for surgery that day, they need to be accompanied by someone because they're not going to be able to drive home. Even if they are fully awake and leave the hospital and seem to be fully awake, there are liabilities that go along with having had anesthesia. Legally, we cannot allow them to go home driving. So it's very important for you to know that if someone comes in and they're not accompanied by a competent adult that can drive them home, or they've not made some kind of arrangements, we cannot do surgery on them that way because legally we cannot allow them to drive themselves home. That's important for you to know. So one of the first things we do is a patient interview. And what we use this for, this is pre-surgical. This can be done several days before the surgery, or it can also be done the day of. And we use this to obtain health information. This provides clarification of information about the surgery itself and the anesthesia. And we also use this for a portal or an opportunity to get pre-op labs and testing if necessary. This is also a key time for us to communicate with other members of the healthcare team. So if something's not quite right. And I'll give you an example. My son was scheduled for same-day surgery a couple of weeks ago. He went to his pre-op testing. He had an upper respiratory infection, and his surgery was canceled. And so that happened 2 days before his surgery was scheduled. So it's a perfect example of communication between team members. So during this time, they obtain health information. You use this opportunity to do some teaching to make sure you know what the patient knows about the surgery. They also have a visit with anesthesia. And then we can draw labs if we need to do any kind of radiology testing if that's necessary. Okay, so the overall goals that go along with preoperative patients, we use this to identify any kind of risks that are that the patient might have. And we also use this time to identify a plan of care and make sure that's a safe plan of care for the patient. So we go into what is considered a subjective kind of a data find for the patient. And with that is a psychosocial assessment. And the 3 common areas that we look for are anxiety, common fears, and then hopes. So with psychosocial stress, that can have a huge impact on the physical being. Stress can elevate the blood pressure, it can increase the heart rate, and it can exacerbate a really already high anxiety level of stress for a patient. So we want to do our best to identify these situations and bring that level of stress down as much as we can for the patient. The high level of anxiety or stress can also affect the recovery time. If we can identify a patient's actual or perceived stressors, we might be able to prevent undue stress. So factors that can influence stress are things like age, their past experiences with illnesses, with pain, maybe some of their current health issues, socioeconomic status, and definitely that has a huge impact these days, whether they have insurance, whether they financially have the means to pay for something like this. Another thing that we identify is language barriers, cultural barriers. Definitely we need to make sure that we are using a language that they understand, even if they're English speaking. If we speak medical jargon and they don't understand it, that just tends to raise their level of anxiety. So make sure you speak in a common language with them that they can understand, and that they leave the pre-op visit that day with full comprehension of what we're going to be doing with them. We also need to make sure if there is a cultural barrier, a language barrier, that we use a translator. And although many people will bring an English-speaking family member into an interview with them, we need to make sure that this person is competent of interpreting in medical terminology or medical terms. So I caution you about using a family member for translation. We might actually need to use a language line, and make sure that we have good communication with medical terminology, or in terms that medical terminology can be understood. And then we also need to make sure that we have communication of the situation with all of the team members. So with anxiety, we know that anxiety can impair cognition, decision-making, and coping abilities. Anxiety can also arise from a lack of knowledge and unrealistic expectation. The other side of that is we also know that quality information lessens anxiety. Anxiety may arise from conflict with intervention. So if a patient knows that there's a possibility of blood transfusion, and this is a conflict with them for religious or cultural beliefs, then this may raise their anxiety level. So these are things that we may talk through with them and help them understand. Some of the common fears that patients might have might be death or disability. And these are things that we talk about with the patient. Patients have actually postponed or even canceled surgeries because of impending fear of doom. And it also has the ability to influence the outcome of their surgery. If a patient comes to you and tells you that, my mother died in surgery, I'm so fearful of going through this, this is your opportunity to let them talk about this situation. You don't just blow this off and say, that was 20 years ago, that never happens. You offer them the opportunity to talk about this situation and see what's bothering about them. Plus, this might also be a fact-finding situation for you, because in a minute we're going to talk about some family history. But if someone relays to you that they have a deep fear about dying in surgery, you want to explore this possibility and just say, no, that's not going to happen. Another influencer is pain. And a lot of people have huge fears about pain. In this interview that you have, the patient should also be set up to see the anesthesiologist that day, and they will talk through the process of anesthesiology and hopefully reassure the patient that pain will be controlled, and they shouldn't feel the surgery at all. They will be given drugs that will help them go to sleep and not remember what goes on. Another situation that may come up is that they feel pain over the loss or the alteration of their body image. So we need to be very sure and transparent with the outcome that they expect is realistic to what is actually going to happen. Again, anesthesia will visit with these folks, and they should get a full accounting with anesthesia of what they will expect to have as far as sedation. And at that time, anesthesia will also go over consents with them. And then we also need to talk to them about the disruption of their life and functioning. Is this going to be a short-term recovery? Is it going to be a long-term recovery? Is it going to be a permanent situation? And at that point, we may also need to include family members. We need to address any kind of financial concerns. And we may also need to get some consultations in place for them, depending on what the situation is. Okay, so moving on to hope. And yes, this needs to be addressed because hope can be a very strong positive coping mechanism. Never deny or minimize this aspect of coping. A lot of people put a lot of faith in surgery for going forward and being something good, such as in reconstructive surgery like plastic surgeries, or total joint reconstruction. Now I'm going to be able to do all those things that I could do and haven't been able to do for the last 10 years. We also do surgeries for palliative reasons, and we need to make sure that the hope is realistic, especially in a palliative situation. Palliative means that it's not necessarily a cure, but it is a relief of symptoms. We can also do surgery in situations where we're doing an organ transplant, or we've got maybe a repair of an aneurysm. So all of these are situations where we offer the patient hope. All right. So let's move on. And we're going to look at a couple of things. We're going to look at the past medical history of the patient. And this is your interview, so we're going to talk to the patient, and we're going to talk to them. We're going to ask them about any kind of diagnosed medical conditions, anything that's going on currently and has been going on previously, whether it's resolved or not. We need to know about it. We need to know about any kind of previous surgeries and problems. If they're female, and usually age 50 or less, we need to know if they are having menstrual cycles. And we also need to know their obstetric history. And even if they tell you that, I haven't had a period in 12 years, and they're 38 years old or they're 40 years old, probably the anesthesiologist is still going to order a pregnancy test just to make sure. So what do you think you would do if you had a patient that was maybe 45 years old and told you that their periods are irregular at this point, but they haven't had a period for 8 weeks? Would that ring a bell for you? It should, because this is a patient that could potentially be pregnant. So at this point, we would want to just validate that and get an HCG, do a lab draw. Better to rule out the fact that the patient might be pregnant than do a surgery with anesthesia on a patient that is pregnant and we didn't know it. We also are going to go over any kind of a family history with the patient. We want to look for any kind of a family history of cardiac disease, vascular disease, respiratory disease, because sometimes those situations run in families and could influence the patient. We're looking for any kind of reactions or problems to anesthesia. So if a patient tells you that their father or a parent or a relative, like a brother or a sibling, died in surgery and they were told it was a reaction to anesthesia, this is something that we pay attention to. That is important because there has been a genetic link made to something called malignant hyperthermia, which is a reaction to anesthesia. We want to know about this. So if a family member, if a patient tells you that they've had a family member that has had problems with anesthesia. This is important. We document this and we pass this on to the medical team. We're going to go over a list of current medications with the patient. We're looking for both prescription and over-the-counter medications. Herbal supplements like garlic, vitamin E, things like that can increase bleeding times. Things like ginseng can increase blood pressure. So these are just as important in knowing that the patient is taking those as prescription medications. So if a patient told you that they were taking maybe garlic and ginkgo, that would be important. You need to document that and then let the physician know. It's not necessarily for you to tell the patient to stop taking these over-the-counter drugs, these herbal supplements, but it does need to be addressed. So this is information that goes to the provider. Generally, the rule of thumb is that the patient will be told by the provider to stop taking herbal supplements 2 to 3 weeks prior to surgery. That's a general rule of thumb, but that rule comes from the provider, not from the nurse. But we are also the people that kind of cue in the provider. We're also looking for any kind of dietary supplements, and we're looking for drugs that might be antiplatelets or NSAIDs. So if the patient is taking aspirin, or they take a lot of ibuprofen or Aleve for pain, this is something we need to know about because that will increase their bleeding time. And then, of course, we need to know if they take any kind of recreational drugs. And that includes alcohol. Drugs, alcohol, and tobacco. Those are all 3 big, important recreational type drugs that we need to know about. Just recently in the hospital I work at, we had a patient that came in for surgery that had a very successful surgery, and we knew in advance that although the patient did not admit to it, the family did admit that the patient was known to have a couple of beers a night. So we knew that probably we were going to start seeing some signs and symptoms of alcohol withdrawal. What the patient nor the family told us that along with those couple of beers, there was some heavy use of vodka. And the patient did go into some pretty dramatic DTs and ended up back in one of our intensive care units on CWA protocol. And he was pretty out of it. It was a pretty traumatic path to get him back there because he went into DTs on the floor. Had we known that in advance, we would have started him off in the critical care unit and protected him from going into DTs. So it's very, very important that we know in advance any kind of recreational drug usage. All right, let's talk about allergies. Allergies are very important. We're going to talk about drugs and non-drug allergies. Of course, we need to know drug allergies, and we hope that people know what they are and remember to write them down and bring them in. By the way, do you know what your drug allergies are? Does your family know what your drug allergies are? A non-drug allergy that is important for everybody to know is a latex allergy. Do you know if you're allergic to latex or not? If we're a healthcare worker, we have a higher opportunity of being allergic to latex because we are constantly exposed to it in the gloves that we wear, the supplies that we use. Some people don't necessarily have that constant exposure, and they're not necessarily aware if they have a latex allergy. So there are other things that they might be allergic to that could be a trigger to whether they would be allergic to latex. So some of those things, if a patient tells you that they have had a reaction to things like eggs, avocados, bananas, chestnuts, potatoes, and peaches, those trigger for a latex allergy. So if you're doing an interview and a patient tells you, hey, I'm allergic to bananas and avocados, that would be an indicator to you that maybe we need to screen this patient a little bit closer for a latex allergy. A latex allergy just means that we change what we use on the patient a little bit, but we're very cautious because latex allergies can be severe. We're also looking for contact urticarial or dermatitis, and we'll protect the patient a little bit there. and any kind of aerosol reactions. All right. Now we're going to move on to a review of systems. And we're going to move through some of these pretty quickly. And so when we look at the cardiac system or the cardiovascular system, we're going to do some things with the patient. We're going to look at some reports. We're going to talk to them. We're going to ask them if they have any current cardiac problems. If they do, we're going to do some monitoring during surgery. One important thing you need to ask them are, have they had any valve replacements, or do they have a history of any kind of rheumatic diseases like rheumatic fever? If they do, those two indicate right off the bat that they're going to get some kind of a prophylactic antibiotic. So those are two important things, and I'm going to mention that again. We also need to know if they are using any kind of cardiac drugs, because we'll need to decide if they're going to have those pre-op or not, and if they're going to be given orally or not. We can also elect to give those IV, and we'll monitor them a little bit closer. We also need to know if they have a pacemaker and if they have an internal cardiac defibrillator. We're going to do a 12-lead EKG on almost everybody, and we'll look at coagulation studies, and we, again, possibly will give some prophylactic antibiotics related to a cardiac history. Respiratory system, I've got a couple slides on this. We inquire about any kind of a recent airway infection. Have they had an upper respiratory tract infection? And again, this got my son a couple of weeks ago. He was supposed to have surgery on Friday. On Wednesday, he came down with a scratchy throat. By Thursday, he had a full-blown upper respiratory infection, and that delayed his surgery. Does this patient have a history of dyspnea or coughing or hemoptysis? If so, we're going to let the operative team know this. Does a patient have a history of COPD or asthma? If so, they have a high risk for atelectasis and hypoxia as a result of surgery. And these are the patients that we're going to do a lot of teaching with. These are the patients that need to know how to use the inspirometer. And we need to make sure, we're going to do this with everybody, but we need to know for sure that they are aware of what they have to do with their inspirometer before they go to surgery. If they're a smoker, we want to encourage them to quit at least 6 weeks before the procedure. Smoking decreases the risk of, this would decrease the risk of complications. The longer they've smoked, the higher their risk for complications are. And then we're also going to ask about diagnosis of sleep apnea. If a patient wears CPAP at home, that definitely has some implications for them. We're going to look for patients with obesity and any type of known airway deformities and acute respiratory function. All right, let's look at the nervous system. We're going to do an evaluation of their neurological functions. We're going to look for any kind of vision or hearing loss that can influence the results. We need to know what their baseline is so that when they come out of surgery and there's a deficit, we know where they were to begin with. We'll do cognitive deficits can be affect informed consent and cause adverse outcomes during and after surgery. And I'll talk about the cognitive deficits here in just a little bit. But we do need a clear baseline on neuro assessment. All right, let's talk about the genitourinary system. We need to know if there's any kind of a history of urinary or renal diseases, and we need to do an assessment for renal dysfunction. We may actually need to do some renal testing. We're going to look for fluid and electrolyte imbalances. We would look for an increased risk. This would indicate that there would be an increased risk for infection. It would also indicate that there might be some impairment in wound healing. And it also indicate that there might be some alteration in the way they respond to the drugs that they are given, because a lot of the drugs are cleared through their kidneys. We also need to note any kind of problems that they might have voiding and let the operative team know. And again, if they're female, we're going to assess for pregnancy. hepatic system. We know that our liver plays a key role in clearing a lot of drugs, so we're going to do liver function tests and make sure the liver is working well. Hepatic dysfunction may increase the risk of postoperative complications. Integumentary system. Any kind of history of skin or musculoskeletal problems we need to look at and see how that's being treated and what the outcome of that was. We need to pay attention to any kind of history of pressure ulcers. If we get patients in, especially that are immobile or coming from nursing homes, we may need to put some extra padding on the surgical table. The OR tables are simply a slab of metal. There is no padding on them. So to protect the patient's already compromised skin, we can put padding on. We also need to be very aware of body art, tattoos, and piercings, which are becoming more and more popular. Besides the fact that these people have spent lots of money to get their pretty artwork, we don't necessarily want to pierce those areas because there is a certain amount of scarring there, and there is a higher risk for infection in those areas. Musculoskeletal areas, we need to identify any kind of joints that are affected with arthritis. Any type of mobility restrictions may affect the positioning during surgery and then ambulation after surgery, and we would go over that with our pre-op teaching as far as ambulation afterwards. This tells us that we bring mobility aids to surgery. Honestly, I have not seen that. They're talking about walkers, crutches, things like that. I have not seen that, but we'll go with what the book says. We need to report any kind of problems affecting the neck and the lumbar spine to the anesthesiologist. That's what the ACP is, the anesthesiologist, because this can affect airway management and anesthesiology or anesthesia delivery. So any kind of neck or lumbar problems, the anesthesiologist needs to know about. Moving on with the endocrine system. I think I've got 3 or 4 slides on this, and this is important stuff for you to know as a lifelong nurse, because there are some things that you will run across here. So first of all, patients with diabetes mellitus are especially at risk for either hypo or hyperglycemia. They're also at risk, that puts them at risk for ketosis. We know they already are at risk for cardiovascular issues. They have delayed wound healing, and they are at risk for infection. So if they're insulin dependent, well, regardless of whether they're insulin dependent, it's going to be a physician call what they do with their insulin the night before and the morning of surgery. That is not your call. That is the physician call. You will want to, if you are the pre-op nurse, you will want to do a blood glucose level before they go back into surgery. You will want to know where they are and want to know if you need to give a dose of insulin per the doctor's order, or if they are hypoglycemic and need to give a little bit of dextrose. So know that you just need to do a blood sugar the morning of surgery to see where they are, regardless of what has been ordered for them the night before with what they're, as far as eating and blood sugar and insulin dosages or oral hypoglycemics. Okay, patients. Yes. Patients with thyroid dysfunction. They can either be hyper or hypothyroid, and this can pose a surgical problem because of the altered metabolic rate. And this information needs to, you need to make sure this goes to the anesthesiologist, because he or she will give the orders whether they are going to take the thyroid medication or not. This is very important. We don't want to throw these patients into a thyroid storm. So this is an important assessment piece of information that needs to go to the anesthesiologist. Patients with Addison's disease. We don't want to abruptly stop the replacement corticosteroids, because this could also cause an Addisonian crisis. The stress of surgery may actually require an increased dose of IV corticosteroids. So again, this information needs to go to the anesthesiologist and the primary or the surgeon, and they will need to make the call of what happens with these patients' drugs. Okay, the immune system. Patients with a history of compromised immune system or use of immunosuppressive drugs can have delayed wound healing and be at risk for infection. Enough said. We're going to assess our patient's fluid and electrolyte status. We hope that if this is elective surgery, we're not going to have any kind of vomiting, diarrhea, or swallowing. Swallowing could be, but if it's emergent surgery, we could have these. So we need to assess for their rate of dehydration. We also need to identify any drugs that could alter their fluid and electrolyte status, drugs like diuretics. And those may actually need to be held, but again, that's a physician call. We would identify the fact that they're taking diuretics and let the physician know that. We will evaluate their serum electrolyte levels. So it is important for you guys to know your normal lab values. Let me say that again. It is important for you all to know your normal lab values. NPO status. These patients are going to be NPO usually, typically midnight, the night before, starting the day of surgery. So if I've got an 8 a.m. surgery, I'm going to be NPO after midnight. The night of, or so midnight, my surgery is Monday morning, Sunday night, I'm going to be NPO at midnight. If I'm dehydrated when I get in, they may run a liter of fluids through me before I go back to surgery. Okay, nutritional status is a big one. We're going to assess for both undernourished and overnourished. So if we have obese patients, we know there are some risks that go with this. We know that obesity stresses the cardiac and the pulmonary systems. We know that there's an increased risk for wound dehiscence, for infection, and incisional herniation. We also know that there is a slower recovery time from anesthesia because anesthesia likes to go into all those fat cells, and it takes a while for them to come out. And just in general, there's slower wound healing. So those are all things that go along with obesity. For folks that are underweight, we actually, again, will think about putting some extra padding on the surgical table to prevent ulcers, and especially if they're going to be laying there for several hours. And then when they come back to the floor, we might think about a specialty bed for them. And for the obese patient, too, we might think about a specialty bed. For the underweight patient, we might also think about protein and vitamin supplements for them. We can identify any kind of dietary habits that may affect recovery. And although we don't necessarily think about it, caffeine is a big deal, especially for people like me that drink a lot of coffee. If I have to have surgery and they tell me I can take my morning meds, I automatically throw an Excedrin tablet in there because of the caffeine content, because I am a heavy coffee drinker and I don't want to deal with that coffee headache. That also, we'll talk about that in a minute, post-recovery. Sometimes withdrawal from caffeine can mimic an anesthesia headache. So that's also a question that you might ask in your interview is how much coffee do you drink, or sodas are another source of caffeine. All right, so let's move into the objective portion here. And I just got my notes off. I did. There we go. Okay. Now let me get this back on. There we go. Okay, so the Joint Commission tells us that we have to have a history and physical on every patient before they go to surgery, and this is the responsibility of the surgeon. This is so that the anesthesiologist is able to rate the patient for anesthesia administration. We also need laboratory and diagnostic testings, and that's to evaluate where they are and if they're stable enough to go back to surgery. And notice that I've got in here monitor blood glucose for patients with diabetes. That's the second time you've heard that. So we're going to do that before they go off to surgery. Preoperative teaching. There are a couple of things, rights that we want the patient to have. The patient has a right to know what to expect and how to participate. This increases patient satisfaction. It also reduces fear, anxiety, stress, pain, and vomiting. So several days before surgery and even the day of, we're going to ask the patient to come in and we're going to do education. And there are basically three types of education we do. We're looking for sensory, process, and procedural. We're going to ask you to document the education you do. And there is a specialty unit that does this. This is not what you do on the floor. There is a same-day surgery or a pre-op area that does this. This is specialty nurses. You're trained to do this. But we do this so that we have a baseline of where the patient is, so that when they actually come in day of surgery, we can assess what they've learned. And then we hope that this avoids a duplication of redundant information. Okay, so we are going to do some teaching, and this is very important. We are going to make sure that we teach the patient to deep breathe, cough, and the importance of early ambulation. And we're doing this preoperative so that they know what to expect, so that they are clear when we teach them this, and they don't have anything else on their mind. They're not in pain or less pain, pain from surgery. They're not worried about an incision at the time. They have family members with them, we hope. But this is done in pre-op, and it's very important. We want them to pay attention to this, and I want you to pay attention to this because it's very important that we do this in pre-op teaching. If your patient actually comes in through the ER and they're going to go to OR the next day, then this is your responsibility. These patients aren't going to go through pre-op teaching. You're going to do this. And we teach them deep breathing, coughing, exercises, and the importance of early ambulation. When you get back from surgery, within the first day, we're going to get you up and walk. That's important. We also want to give them the information that if they come back from surgery, they might have drains or tubes hanging out of their body, so that they expect this. And then if there's anything special, like they may not come back to this unit, they may go to the intensive care unit, or if they're having some kind of a knee surgery, they might come back with a passive range of motion machine on or something like that. We need to give them full information so they know what to expect. For outpatient surgery, we also need to give them basic information of when to arrive, where specifically to arrive, what time to arrive, where they're coming to in the hospital, and again, be specific. If they're headed for a 7:30 OR, they're going to have to be there at 5:30 in the morning. We want them there at least 2 hours in advance. And yes, we'll be there. Hospitals are open 24 hours a day, so yes, we'll be there. Somebody will be waiting for you. The light will be on. They need to know their fluid restrictions. Can they have a light meal the night before? They stop eating at midnight, nothing to eat or drink. That includes, you can brush your teeth, but don't swallow. Let them know if they need to have an enema. Let them know if they need to have a shower, especially if they have to use some kind of special soap for the shower. If they need to shave a certain area, they can do that at home. There's not a problem with that. Um, let's see. Okay, legal preparation. It is the nurse's responsibility to make sure that all forms are on the chart and to know if the forms are signed on the chart. It is not your responsibility to get the patient to sign them. Informed consent is the responsibility of the physician, not the nurse. That's important. Let me say it again. Informed consent is the responsibility of the physician, the surgeon doing the actual surgery, not the nurse. There are several things we get consent for. Informed consent for surgery, consent for blood transfusions, advance directives, power of attorney. I think we've already talked about those in previous classes. Consent for surgery. Informed consent must include adequate disclosure. In other words, we have to describe to the patient exactly what we're going to do. The patient needs to verbalize or acknowledge that they understand and have a comprehension of what is going on. And then they have to voluntarily give consent. We cannot coerce any kind of answer from them. And let me use my son as an example. You all know that he just had an inguinal hernia repair. He's 24 years old, competent adult. I was with him in pre-op that day, and I think 3 different people asked him about his surgery, and they did a great job with him. Asked him in plain language, "What are you here for today?" And he described to him what was going to be done and acknowledged what side it was without prompting from them. He had already signed his informed consent. I think they did a great job with him. All right, let's see. Again, the surgeon is responsible for obtaining consent. The nurse may witness the signature, and chances are you will be a witness. That's not a problem. You can witness anything. Verify that the patient has understanding. If you have any doubt whatsoever that the patient understands what they're signing for, I would not sign. You don't have to sign. Also know that the patient can withdraw their permission at any time. So here's a question for you. If you've got a patient that goes ahead and signs their informed consent, and you agree with the physician is giving a great explanation of what's going on, and you think the patient has understood, they sign, you sign, everybody is happy with this. Let's say the patient's going down for a hysterectomy, and surgeon goes on down, and while you're talking to the patient after the fact, she says, "Oh yeah, I'm going to have this hysterectomy, and in another couple of years, my husband and I are going to try again to have a child." What would you do? At that point, I think you can recognize that this patient just doesn't understand what's about to happen to her. And at that point, you say, "Okay, hold on a minute. The doctor just reviewed with you what's going to happen, but I think we need to have him come back up and talk to you because the patient does not understand." And at that point, you become a patient advocate again. And so you just put the brakes on everything. You get on the phone and you call the physician and you explain what has happened. He or she is probably going to have you send that patient down to holding. And he will talk to them down there again. You will document what you have done. Patient has said, made this statement to me. I have called the physician. He understands the patient does not fully understand what's going to happen and has asked for the patient to be sent to holding, and we'll speak to them there. All right, let's see. In situations that are medical emergencies, the physician can override the need for consent, especially if there's no one there. They can document a medical emergency and take the patient to surgery. In situations where there are minors, the patient is unconscious or mentally incompetent, we can, a minor, we have to have adult or the parental or custodial guardian consent, unless it's a medical emergency. Unconscious patients, we have to have either the spouse, the parents, the siblings, whoever is the closest relative for consent. Mentally incompetent, we have to have a legal guardian for. If you run across a situation with an emancipated minor, that is a minor that is less than 18 years old, but has gone to court and declared themselves an emancipated minor, they can sign their own consent. An emancipated minor can sign their own consent. You can get telephone consent. I've had to do that before. You get a second person on the phone line with you. Full disclosure is given to the person on the phone for the procedure. That person gives verbal consent over the phone, and then both people listening sign the consent form. Let's see. Okay. So the day of surgery preparations, patient comes in. We're going to review our final preoperative teaching. We're going to go through all of our assessments and our report any pertinent findings. What happens if the patient comes in and says, yeah, I woke up at 4 o'clock this morning and had a quick cup of coffee? We're going to report that. We might delay their surgery for a couple of hours so that coffee clears. We're going to look through their labs. Labs should be back. What are we going to do if we see a lab, maybe a potassium value reported at 3.2? That's a little bit low, so we might want to circle that and make sure that the provider knows that. We're going to make sure there's history and physical on the chart. We're going to grab a quick set of baseline vitals, make sure they're within that normal range we like to see. Make sure any kind of consulting records are on the chart and any kind of nurse's notes are there. We're going to ask the patient to shimmy into one of our wonderful little hospital gowns and ask them to take off all of their clothing, because really we don't like to send them back with any kind of garments. We will already have asked the patient not to wear any kind of cosmetics. If they do, we're going to ask them to politely take it off. That includes nail polish if it includes the capillary beds, because we want to be able to see their capillary refill. Any kind of valuables are given back to the family to hold. So glasses, hearing aids, dentures, contacts, and yes, prosthesis. We have seen family members walking through the hall holding onto a leg. Those are given back to the family. If there's no family there, we usually have a place to lock them up and store them. We want to make sure that the identification band is on for the patient, so that and in the typical place, if your hospital has a policy of putting them on the left wrist, that's where it goes. And we want to make sure that allergies are listed there too. We want to offer the patient the opportunity to get up and go to the bathroom before we give them any kind of medications. This is important. Insist that they get up and go to the bathroom if at all possible, because after you give them medication, we're not going to get them up. Even if they say 2 seconds after they've taken that little Valium pill, we're not getting them up. We're offering them a bedpan or a urinal. They're not getting up. It is a safety risk. It is a policy of the hospital. They're not getting up. And you can tell them that in advance. They're not going to get up. Once they take those pills to help them start getting relaxed for OR, they're not getting up. So let's talk about some of the medications that we give them. Oh, and backing up, about the time you're starting to give them the pills to help them relax, remember we're going to do a blood sugar at that time and just gauge where they're, if they're diabetic, where their blood sugar is. All right, so some of the medications that we're going to use with patients are these drugs, benzodiazepines. These are the sedatives and the amnesiac drugs, so it helps them relax, and it's also going to make them forget a little bit of what's going on. Valium is one of those drugs. Great little drug most of the time. Anticholinergic drugs, and atropine is one of those drugs. Typically they'll receive that downstairs in the holding area, or in the holding area. I don't know where downstairs is, where it is in my facility. And one of the side effects of atropine is that it's going to help dry up the secretions. That's why we give it, because we don't want someone slobbering all over and swallowing or aspirating mucus while they're unconscious. So we're going to help dry up their secretions a little bit. So once we give that drug, if they complain of having a dry mouth, you can explain to them, well, you've received some medication that helps you dry up the mucus a little bit, and that's why. We're not going to offer them water. Just explain to them that's the side effect of some of the medications we've given them. We can give them opioids. They may not be aware of it at the time, but typically we give morphine and fentanyl. That's for pain relief. It also helps enhance the anesthetic qualities of some of the other drugs that are given. We give antiemetics. That's to relieve their sick-up response. We don't want them to be nauseated and vomit, especially if they've got an abdominal wound. And then we're going to give antibiotics, and we can give those for a variety of reasons. As I talked about, if the patient has a history of heart valve replacement or rheumatic fever, we're always going to give preoperative antibiotics because we don't want to encourage an infection. And those two conditions set a patient up for infection. If they're going to have a belly wound, we're going to give preoperative IV antibiotics. There's been a national patient safety goal set a couple of years ago that tells us that if we give IV antibiotics between 30 and 60 minutes pre-cut time, our surgical infection rate goes way down. And that has been a nationwide evidence-based practice that has shown extreme effectiveness in reducing the rate of post-surgical infections. Okay, transporting to the OR. This was a little interesting. I've been a very long time since I've seen anybody transported in a wheelchair. We like the stretcher. The stretcher is good. If we're transporting children, we can always use the big red wagon sometimes. It makes kids feel really cool to be pulled through the hall in the wagon. We do a communication handoff once we get there, and that is SBAR, Situation Background Assessment and Recommendation. And the recommendation is usually reserved for anything that I didn't get done on the floor. So if I still need to give drugs, or if there's been some kind of special request with an IV, that might be something in the recommendation. The one thing your book left out was a timeout, and that's done after the handoff, but once the patient transitions back into the OR room. And it's very important because it's a time frame where everybody stops in the room and they review exactly what's going to be done to the patient. If the patient is awake, the patient participates in it. But this was done, again, this is another national patient safety goal. We had gotten into several situations where the wrong patient was taken to surgery, the wrong body part was removed, several different major errors, and the timeout was put in place to simply try and combat any kind of errors. So I'm going to throw that into the communication handoff. Then the last thing we're going to talk about are cultural competencies. And I just need for you to know that different cultures have different needs. In some cultures, pain is dictated. The way you express pain is dictated by the culture. Some patients won't express pain themselves. They will express it through their family members. Other families, or some cultures, will only communicate or allow communication through family members. Also be aware of language barriers. And again, I go back to always use a medical interpreter if there's any question at all whether there's competent communication. And then geriatric considerations. Make sure that you assess the patient's cognitive abilities. With older patients especially, they can have vision and hearing losses, and that sometimes requires us to be slower in the way we approach them and take more time with them. And that's okay, because we need to do that. We need to do what's right for the patient. They still have the ability to understand. We just have to speak a little bit slower and a little bit louder so they have the ability to hear us. In situations where you have a married couple where the husband does all of the speaking or the wife does all of the speaking, but yet it's the other one that is the patient, you may have to include both of them and make sure the patient actually hears what's being said and sees what's being said and responds. Especially for education, because it's not if it's the wife that does the speaking with the husband that's doing that's having the surgery, it's not the wife that's going to do the coughing and deep breathing. It's the patient, the husband. So you have to make sure that he's the one that gets the education, even though she's answering the questions. If he's the one with the hearing deficits or the vision deficits, he has to make sure, or you have to make sure he gets the message of the teaching. She can't answer for him. The other thing I want to mention about geriatric is, especially with our elders, many elders believe that going to the hospital is one step away from either death or going to a nursing home. So their perception may be extremely different. They may be looking at this as, oh, I'm going to die. If those fears come up, please address them and please respect them, and encourage those patients to talk and get them the support that they need. And I think that's all I have for you in lecture today. So that's the end of chapter 18.